Welcome everyone to the program today. We're happy to have you here. So I'd like to know if you can see my slide.
Yes.
Okay. So thank you already for that introduction. Today we'll be talking about asthma in children, which is a very important topic, as it's the most common chronic disorder in children worldwide. Nigeria is not exempt from that. So what is asthma? I'm sure we've all heard that term. And basically, it's a chronic or long-term condition or disease in which a person's airways in the lungs become inflamed, which lead them to become narrow, to swell, and to produce extra mucus. And this makes it difficult to breathe. So a long-term or chronic condition means it's something that the person lives with every day. And when somebody has asthma, it manifests as recurrent symptoms. The symptoms that the person has that come in a recurring way are cough, chest pain or chest tightness, difficulty breathing or shortness of breath, and wheezing, which is simply a wheezing sound or whistling sound, heard when the person is breathing out. And these symptoms may be worse at night or early hours of the morning, which is something that is quite peculiar about asthma. And so how does it occur? It comes about from an interaction between the genes and the environment. And what this simply means is an individual who has asthma has inherited that tendency to have an exaggerated response or hyper-responsiveness to substances. So we're all in a room and it's the person that has asthma who would start coughing or having chest tightness or wheeze when, for instance, palm oil is being fried in the kitchen and the smell comes to the sitting room. So it's a genetic disorder, but unlike other disorders like sickle cell, for instance, where we know the actual point on the DNA where there's a mutation, here we don't know. There are many genes that have been associated with asthma, but what we do know is that it runs in families, and that's what gives us that indication that it's something that has to do with the genes. But then what does it mean? Does it mean everybody who has inherited that gene to have asthma, or somebody in the family had asthma? Does it mean everybody would have asthma? No. So the expression is variable. It can skip 2 or 3 generations. And sometimes a person may have asthma not present in childhood, person may present later in life. So it has to do with interaction between inheriting the gene and now being in an environment where the person now has or comes in contact with the things that would trigger that abnormal response. And so when this person, this individual who has inherited this tendency to react, now comes in contact with some, we call them triggers. So some, it may be something in the environment, it may be a particular situation that occurs, and these triggers may be known or not known. So we're talking about children now. So these triggers, the parents or the caregivers, or if it's an older child, they may not necessarily know what exactly is their trigger. And so what are the common triggers? The common triggers, these are things, like I said, that would, make that person to have this abnormal or exaggerated response, are things like dust. So dust mites, these dust mites stay within, especially the beddings, and then, would cause the person to react. So things like mold, animals, so the fur or the feathers from animals, or even their dander. So the dander are just pieces of or particles of skin or dried saliva from these animals. If the person comes in contact with them, then person can have these symptoms that we've said. So other things are things like cockroaches in the house. So even the dead cockroaches, the particles of the dead cockroaches in the house, the presence of that can trigger this. Pollen from flowers, grass, food, so dairy products, seafood, wheat, nuts, strong smells. So here we have a lot of mosquitoes, we have people spraying insecticide. So chemicals, fragrance, perfumes, air pollution, both indoor and outdoor. So indoor, you have secondhand smoke from somebody smoking cigarettes, or fumes, from, cooking, or generator fumes in Nigeria, where we have a lot of people using generators. Generator fumes coming into the home can cause that. And then outdoor pollution, we have a lot of cars, emitting a lot of carbon monoxide and other gases that are harmful. If children, have come in contact constantly with these substances, then they can trigger asthma in them. So exercise, stress, it can be probably during exams, or you find out that probably when the child goes to a party, running around, jumping on the bouncy castle, a few minutes later starts coughing or having any of those symptoms I was talking about. So emotion, child can be crying or be upset or be laughing and suddenly, start having these symptoms I was spoken about. So weather, so things like thunderstorms, or even during winter when it's cold, or harmattan, cold and the dust during harmattan, both of these can trigger asthma. Hormones, so for older children, some of them start having it when they start having their periods, because it's the hormones that are triggering their asthma. Respiratory tract infections, very important. One of the biggest triggers, especially in children less than 5 years. Usually viral infections, but it can also be bacterial or other microorganisms. Sorry. My slide is not advancing.
Maybe try clicking on this. It's working.
Okay, sorry. So this is just showing, just a picture of what I was talking about before. So any of these things are the common triggers that could trigger asthma attacks in children. So asthma can affect children of all ages. So that's one thing I want us to note today, because a lot of people think babies can have asthma, children under 1 year can have asthma. Children, people of all ages, and children even under 1 can have asthma. In most children, the symptoms are mild, so they may not have symptoms maybe once a year, or very infrequently. We call that intermittent asthma. But for some of them, it may become more severe than that and start interfering with their daily activities. It may lead to life-threatening asthma attacks or flare-ups. So attacks are just periods in which these symptoms that we've spoken about earlier become more intensified and more pronounced. And so another important thing about asthma is that the symptoms are variable. So in an individual at each point in time may have all the symptoms we spoke about, may have just one, may have them all of the time, may have some of the time. So even in a particular person, the expression of the manifestation of asthma is so varied, and it differs from person to person. Even identical twins would present, the asthma will present in different ways. And so that's very important to understand, because you would hear people saying, oh, the child has been fine, there's nothing wrong. And then suddenly, so the times when you thought the child was fine, those things, the things that are happening, that we spoke about, the inflammation that is happening, at the microscopic level within the airways, you can't see it. And it's only when he now starts coughing or manifesting those symptoms that you will now be able to pick it up, that this child is, having an asthma attack, for instance. It does not have a cure, because we said it's genetic, and as it is, we don't yet have the genetic, so that we don't have any cure in terms of removing that some gene modification that as yet has been able to help with removing that, that tendency to react, from an individual. So it can still be passed on from one generation to the other. So that would be what would be the cure, to remove that tendency for that person to react. But so for now, that has not been discovered, but it can be controlled. And that's what we're going to be talking about mainly today. So there are different types of asthma. The presentation would be too long if we really discuss everything about asthma, but just to note that we're going to be focusing more on allergic asthma, which is the most common type of asthma in children. So there are other types of asthma that don't come through the allergy pathway. Some of them are from somebody being obese, for instance, or you have adult onset asthma that happens in those who are when they're adults, or you have the one that when somebody is being constantly exposed to some irritants, then the person now starts, having these asthma symptoms. So the one we're talking about is the allergic one, where the person responds in response to allergens or those triggers I was spoken about, and then some mediators of inflammation like eosinophils, IgE, that is what happens in allergic asthma. So to make a diagnosis of asthma, usually it's a clinical diagnosis. In most people, you make a diagnosis, especially in children, you make a diagnosis from the fact that this person is having symptoms of cough, difficulty breathing, chest pain or chest tightness, shortness of breath that come recurrently. So if somebody presents for the first time with these symptoms, it may be difficult to say the person has asthma at that point in time, because it could just be the person has a viral infection, person is wheezing, and then it may be a viral wheeze, you're not really sure. But by the time the person starts having it recurrently, then you can say this is likely to be asthma. And then usually when the person has these symptoms in the absence of a fever. So this can be a bit tricky, because in children under 5, a lot of their asthma is triggered by viral infection. So it may be difficult to differentiate between the person who is having that one that has to do with the allergy, with the family history, the inherited one, as opposed to just being a one-off because of an infection. So if a person has these symptoms, like we said, and there's no fever, usually there's no infection, then it's more likely to be asthma. If there's a family history, so this family history, usually when you ask, most people will say no. But when you go back and ask, do your sister's kids or your brother's kids have asthma? Your father, your mother, your grandparents, great-grandfather, you may need to go, back, forward, linearly to find out along the family tree. You will find that somebody has asthma. So either family history of asthma or other allergies. So the person has a family history, or somebody in the family that has hay fever or allergic rhinitis or allergic dermatitis, where they're always, having rashes at their flexures. So that's at the elbow or behind the knee or around the neck, this dry scaly rash and all that. So you may need to really go and ask those kind of questions to be able to get the family history. So family history of asthma or other allergies, you would start suspecting asthma in that individual. And if the person also has, so if that child also has other allergies, so a child that had eczema as an infant, for instance, or is always sneezing, the nose is always stuffy, always, fiddling with the nose, or scratching the nose, scratching the eyes get swollen, especially when probably maybe during if the person lives in a temperate region where they have during summer, where they have a lot of flowers and all that. So once you notice all that, and then the child now starts having these symptoms that we've spoken about, then you start thinking it's likely to be asthma. And then if the symptoms come at night, so we said nighttime, early morning, that's usually when this child that just wakes up, or even sometimes the child may still be sleeping, but you just see that this child is uncomfortable, can't sleep, is always, coughing, having this breathlessness, difficulty breathing, or even the wheeze, especially at night, then you start thinking that this child could have asthma. So usually for children, especially for children older than 6, you need to objectively confirm. So now, though the person has symptoms, you suspect, then you should confirm and make sure that there is evidence of obstruction. And this is what we do when we do lung function tests. So the lung function tests help us to measure the amount of air the person is able to breathe out after taking a very big breath, and how fast that air passes through. So if there is obstruction, which is what happens in asthma, it will be difficult for the person to breathe out. The amount of air and the speed at which that air will come out will be lower than, some predicted value. And then you go on to say this child has an obstructive airway disease, most likely asthma. So the peak flow measurement is done. Will be the next speaker will talk more on that, but that can help us. And then the spirometer is the one you come to the lung function lab and then you do. It can also be done in the clinic, and then you measure, and if it's indicative of obstruction, then you make a diagnosis. Some other things that can help in the diagnosis are things like allergy tests. So you have the blood one or the one you do on the skin. And these help you to, so those allergens, all those allergens we've spoken about, either the food or the ones you inhale, you take a bit of extract of those allergens, especially prepared extracts, and then you inject it on the skin, and then you watch for the reaction. And if the child reacts to the area where it was pricked with that extract, then you say that person is allergic to whatever it was, the substance that you injected with. And then, or you could take the blood of the child and then send it to the lab, and then in the lab, the blood is now mixed with some of those allergens that we've spoken about, and then you measure the amount of immunoglobulin E that is produced, and then if it's high, you say that person is allergic to that substance. So chest X-ray is done usually to rule out other things. So we said, so there's a saying we say in medicine that not every wheeze is asthma. So it's not every child that is wheezing that is asthma. A child that has a bronchopneumonia, for instance, can wheeze. So you may need to do a chest X-ray to make sure that it's nothing else, or it's not some structural abnormality that the child was born with that is causing obstruction of the airway that is leading to this wheezing. So this is just showing the picture of the spirometry that I was talking about before, where the child takes a maximal breath and breathes out, and you're able to measure. And then this is the skin prick test, where you can actually, check for the reaction to any of those things that we've spoken about: mold, the cat, the dog, and all that, and then pollen. And then you can see, if the child reacts, then you can see that reaction, and then you can say that person's allergic to that substance. So how do we manage asthma? So before talking about inhalers, of course, that is the bedrock of the management, but there are other things that have to be done. If these are not done, then your inhalers may not even work. So the assessment and monitoring. So this has to do with making a proper assessment in terms of a proper diagnosis. What type of asthma does this child have? What's the severity? And you use the symptoms, how frequent the symptoms are happening, and also how bad the lung function or how good the lung function is. And putting all this together, you're able to say this child has whether intermittent or persistent asthma. So intermittent or mild, moderate, severe asthma. And then that would now help you to, in monitoring the child and in knowing what treatment to do. And because we said, this obstruction that the child has is not a static thing. It depends on how. So if the child is in a time of the year or in a particular, maybe live in a particular environment where the triggers are a lot, the allergens are a lot, then at that point in time, the obstruction may be a lot. And if the child goes somewhere where the child is not exposed to a lot of things, the obstruction may not be as bad. So it's not even in that same individual, it's not static. And that's why you have to keep monitoring, reassessing, and adjusting your treatment as needed. And education is very important, because this, any chronic disease where the person has to be involved, there's a lot of self-management in asthma, where the person has to, have a lot of knowledge. So about the diagnosis, what causes asthma, or what we've been talking about, in the last couple of minutes, the person who has asthma should know all these things so that they are better able to either prevent or to control their symptoms when they come. Inhalers can be very complicated. There are so many different types of them. We'll learn about that later. And they need to know how to use these, because even if you give the person a prescription and they don't know how to use it, then of course the asthma can't be managed properly. And then also the asthma action plan. This is a written plan that you give to the person who has asthma to know what to do, when they have symptoms. So you write down their symptoms, write down their triggers, tell them what to do when they have these symptoms, and at what point they should go to the hospital. Everything is written there. The amount of inhaler to use, which inhaler to use when you have an attack, which inhaler to use every day to control or prevent your symptoms. And then when, things get out, you would list, for them what those things that they would have, that they will know that this is not something I can manage at home. I need to call 911 or 999 or go to the hospital, depending on what part of the world you're in. And also the environment. So we said genetics, environment. So if the person is on medication but lives in a house where there's mold everywhere, that asthma can never get controlled. So they need to know how to manipulate their environment and control those triggers. And also, there are also coexisting conditions. We call them comorbid conditions, which can be the cause of wheezing or can worsen symptoms in somebody who has asthma. So things like reflux. So gastroesophageal reflux disease, that's the full term. And what that just means is that there are some people that have reflux. Remember, babies, how, when they were really young, when you feed and the food comes back up. So sometimes you can still have that, in older children, and this food comes back up when they eat and then goes the wrong way, keeps going into the airway and irritating the airway, and they can actually wheeze. So if you don't control that, then the asthma symptoms are not going to get better. And then those who are obese. So that on its own can even be cause of asthma without it even being an allergic one, or it can worsen asthma symptoms in somebody who, has the allergic one. And then medication. So we'll hear about that later. So we have two groups of medications: the relievers, that the one that the person uses when they're having symptoms, and the controllers that they use every day to prevent this hyper-responsiveness, this exaggerated response, this inflammation, which happens on a chronic long-term basis. You need to control that so that the person would not have the symptoms. So what are the myths? There are a lot, we can't cover all of them, but some of them which we're dispelling here are things like the fact that asthma is contagious or infectious. And that's why you find some people in schools, they don't want their kids, sitting down or playing with a child that has asthma. It's not contagious, it's not infectious. There's a lot of stigma around asthma. And that's why you find some people not wanting to bring out their inhalers to use it when they're in public, because they don't want people to discriminate against them. So asthma is not contagious, it's not infectious. It cannot be treated by steam inhalation or rubbing mentholatum or rub on the child's chest. The child has a runny nose, just a common cold, that may help. But if a child is having these symptoms that I said in a recurring basis, the steam inhalation is not going to be treatment for that. It's not by anybody, because the first thing you hear when you tell somebody they have asthma is that, God forbid, I reject it and all that. It's a curse and all that. So it's not. We've said it's genetic, and at least on the scientific point, which is what we're talking about here, it's not caused by any of that, and they're not addictive. So some people feel if you use inhalers, you get addicted to them and you won't be able to stop using it. That's not true. And oral medications are not better or safer than inhalers. Inhalers are safe, and they are better because it goes right to where it's needed. And children with asthma can exercise or do sports as long as they're well controlled on their medication. They can actually do exercise. And asthma is not outgrown. That's a very big one we need to dispel today, though symptoms can get better, because we've said some of those things that the child is exposed to as they get older. They have less of those viral infections, for instance, and they're better able to understand, their bodies, and sometimes the body actually gets, how will I put it, because they've been constantly exposed, sometimes the body now sort of gets less sensitized to those things, and then the symptoms get better. But that tendency to react that has been inherited is still there. The DNA hasn't changed. So that person still has asthma, even though the symptoms may get better. Thank you. I think my time is up, so I'll hand over back to already at this point. Thank you.
Fantastic. Okay, thank you very much, Dr. Yeside. It's very exciting, and I'm learning a lot as well. We've had lots of interaction in the chat, and please don't worry if you asked a question and your question doesn't get answered now. It will be, but I'll just pick two. So one of the participants has asked, what would be advised for an asthmatic person who loves exercising, since it was listed as a trigger?
Thank you already. So as I mentioned later, like I said, we're talking about children here now. So I said they can exercise, they can do whatever sports they want to do, but it has to be when the asthma has been controlled. So when the child is still having persistent symptoms, persistent asthma, where they're having symptoms every day, every week, every month, at that point you cannot exercise, because it will definitely make it worse, and you don't want the child to have a very severe attack. So yeah, so you can exercise, but it's at the point where your symptoms have been well controlled, then you can exercise. But then there are some people who do have what we call exercise-induced asthma, where it's only exercise that triggers it for them. So for some of them, there's nothing you can do. All you need to do is you have to give them a reliever medication every time they want to exercise. So they use the inhaler before they exercise, and they're fine. Thank you.
Says, good afternoon. Does persistent use of inhaler or drug for asthma have any negative impact in the system?
Okay, so when you said persistent use, so I assume your question is when it hasn't been prescribed. So if it has been prescribed and a doctor is monitoring the person for response, for side effects, then it shouldn't cause any problems, because then the doctor is monitoring and then would adjust, as needed. But if the person is just using it, unprescribed, it can actually be harmful. The steroids, for instance, can have a lot of side effects, on growth, on, causing things like diabetes, or even adrenal suppression, where the person starts getting obese, and even their blood pressure and all that. So it can be harmful if you're not, well regulated. And even the constant use of the salbutamol, which is the blue one, the Ventolin that most of us are used to, using it, too much can also have a lot of deleterious side effects.
Thank you. Perhaps the participants would like to raise their hand so they can clarify what they meant, so that you can better answer their question, unless they're satisfied. So I think it was someone, you haven't put your name, but your title is Infinix Hot NT. Do you want to add a bit more to your question?
Good evening.
Good evening.
No, I think it's quite clear. I was going to ask the question, and I think it's quite clear, and I understood what she actually meant by the explanation she gave. Thank you very much.